and hand it over to you.
Perfect. I'm just going to get my video going here so we can see. Okay, can everyone see my presentation here? Perfect. All right, see if I can, oops, it has, there it goes. Okay, so my name's, you know who I am. So I'm out in Victoria on the West Coast. I am from Ontario, but I've traveled most of the country. Happy to answer your questions in English or French if anyone so needs that help. And we're going to talk about spasticity today. And I know it's a really broad audience. So, you know, if you see any burning questions in that chat box, Cheryl, please, bring them to my attention.
Absolutely.
What I always say in my career when someone asks, what the heck is a physiatrist? I said, well, we are the doctors that care with how you interact with the world. So our job is to give you the function and ability to what is realistically possible. So for example, if you look at this image on the bottom, we call it a meme today, but most people who go into the hospital, they want to come back out the way they were or better. And so, you could insert whatever image on this character, but people want to be able to walk as smoothly as possible or wheel their wheelchair or move or think or eat with as minimal effort as possible. And we're the doctors that work with our rehab teams to kind of give you back that function. And I think medicine often forgets to ask people, what are your goals when you come see us? So that's our goal, is to get you back as much as possible within the context of disease. Now, the term spasticity is really challenging. It is 300,000 people in Canada have spasticity, probably more with the growing population, yet everyone will define it differently. So some people will call it spastic muscle overactivity. So to kind of give you an example, now no one can see you, so don't worry, is I would like you to grab two hands. If you have two hands that move, if you have one, if you can't move your arms at all, maybe a caregiver in the room can do it. But I would just like you to grip your fingernails in as hard as you can and almost like hurt that your nails go in. And I want you to hold it there and pull in as hard as you can. And then in slow motion, I want you to take one arm that moves and try to reach out, but resist as much as possible. And you're going to slowly open your fingers. So it takes about a minute to pick up a cup. And I want you to think about how much that hurts and how much effort that takes to do that. Well, that's kind of what spasticity is. Spasticity robs you of the ability to move the muscles the way you want to move them. So we need to open an arm by relaxing it, opening it, letting gravity help, and then we need to move it back. But in order to move a limb, we have to want to move it consciously or unconsciously, and everything else has to relax. But in spasticity, everything gets stuck together. So in the upper extremity, it looks like this, and the lower, it points down. Generally, there's many patterns. So that's what spasticity it is, and it affects a lot of people. So in the arm, it often causes this position, but it can cause this position, it can cause this position, it can cause almost any position. In the lower extremity, it often makes your legs so long that your foot won't clear the ground, or you can't bend your knee, or you're stuck in a wheelchair with your legs together. Each patient has their own pattern. So I'll give you an example that even when we treat it, so this was one of my patients, he was a wood carver. He had a stroke in hospital, and we treated him very early with botulinum toxin after a stroke because he was so tight. And I'll talk about botulinum toxin or Botox later. But even after we treated him and his arm worked so well, this was an amazing outcome, he still wants to walk like he has a stroke. So his brain causes his arm to externally rotate, to come up, and his knee is stiff. And we have to say to him, hey, drop your arm, relax. Don't, you can bend your knee, because his brain is not working the way his brain wants to. The stroke took over. So even when we treat it, we have to constantly remind our body how to work. Because after a stroke, we don't have full connection to our body. It might not feel the ground or the environment well. Some patients have problems in the lower extremity, in the leg, that we call a dystonia. So this man, when he walks, his toes curl under. And it's a really hard way to walk, because when he walks, his toes clench up and curl, and they dig into his shoe. And you can see his right hand is actually in a fist as well. So when he wants to go use that hand, it gets more and more of a fist. Now, my colleagues from Germany put together this nice sort of diagram of where the most common stroke patterns are. And if you've had a stroke yourself, you might look like this or have a loved one. But it's not just stroke, it's cerebral palsy, brain injury, spinal cord injury, multiple sclerosis. Many things will cause this. Now, the interesting thing about a stroke is that your nerves are still alive. Your muscles are still working. And we know that we have a nerve that attaches to a muscle and it causes that muscle to relax or contract. In a stroke, it's like it's going all the time. You can't shut it down. So when you want to relax, you can't relax your muscle and stretch. Now, the first question is, do we need to treat it? And there's a lot of arguments. I know in centers where they don't have as much access to physicians or specialist care, they might say, well, we need to let the spasticity play out. But in most of my colleagues, many were physiotherapists or occupational therapists before they became a doctor. They said, well, why do we let a bad pattern play out? Shouldn't we be getting rid of the problem when it starts, like right after a stroke, in order to normalize movement at work? So for me, the first question is the spasticity causing a problem? Is something else causing it? Is there some kind of trigger or bad thing happening? How do we measure it and should we treat it? Like, is it impacting the patient or not? Now, one thing that we know, the urgency of treating spasticity after a stroke early, is that half the patients will develop a contracture. And a contracture means the limb is so stiff that no matter what we do, we can't move it anymore. We can't open the hand more, we can't bend the wrist anymore, we can't lift overhead, the knees are stuck together, the foot on the ground. So even the best therapy won't stop contracture from forming. We also know that we can try to stretch and do as much therapy on its own, but therapy on its own won't stop it. Now, of course, therapy is extremely important and we work together with our physiotherapists every day, but it won't prevent that body from getting tighter. So we need to have lots of teams. So this would be an example of a woman that was on in my service that she has a really stiff, painful shoulder. And you think it's a contracture, but we have developed a technique here that we learned from our European colleagues where we actually freeze the nerves that cause the tightness with some lidocaine, which is just an anesthetic that you get for dental cream or working on your fingers. And we paralyze the nerve, and lo and behold, she didn't have a contracture. We can actually treat her to get her range of motion back. In my clinic, we are doing a lot of novel stuff, so I'll talk about, but this is your classic shoulder. This man, his shoulder is actually coming out of the socket a couple of weeks after stroke. And because of that, his muscle of his chest muscles, his pecs are so tight, he can't get his arm overhead. And he is developing pain every day on the ward. So the therapists are telling us he can't participate, he's in pain. And we do our novel procedure and we paralyze that pec muscle and let the arm go overhead. If you're a therapist, you might know that we use something called the modified Ashworth scale. And it just measures how much stiffness is in the muscle. It's a really not a great scale. It's very changeable. Someone with a stroke will say in the morning my hand opens, but in the afternoon it doesn't. And it just lets me speak with another therapist or doctor to let me kind of know where the patient is, but it's not a real reflection of how they move. Now, one of the most common treatments in Canada, because we have mostly free access for most stroke patients, is botulinum toxin. Now, we often say Botox for the trade name, but there's multiple brands on the market. And what it does is it stops the nerve ending from contracting to make that muscle tight. So imagine you want to do the splits and you can't do the splits because the muscles are tight. It would kind of relax the muscle so you could open your legs a little bit more. And that's what the botulinum toxin does, is it stops the neurotransmitter to relax that muscle for about 3 months. So it's this very incredibly high-tech mechanism. It's not botulism, the disease, but it is defined. So people will say that botulinum toxin is the world's most deadly molecule in a large quantity. It, kill a large population, and it's the most expensive. It's about $4 to $5 billion US a gram. So very expensive molecule, but we use tiny amounts. So it's not going to hurt you. It's safe, but we do need to know there's side effects at high doses. So when you see your clinician for botulinum toxin, if that's something that you're considering going or getting, they will look at the pattern of muscles in your body. So whether your hands like this, open or closed, and they will decide where you should get that toxin to relax those muscles. Now, it does mean in most people, they're going back every 3 months indefinitely. Some people are lucky, a few rounds relaxes them up enough and they don't need to go back. So this would be another case of someone who, and I'm a huge advocate of getting treated right after stroke. So if you listen, you can hear that catch in his elbow. So he was getting a contracture and stiffness in that muscle about 5 days after his stroke. So his occupational therapist and physio said, can you help him out? So we injected Botox into that upper extremity and he's getting better. We also really take advantage of bracing because I said to you, physio on its own won't help. The therapist will brace them to maintain the stretch. And then a month later, he's getting much better function. So by treating him early, he was lucky we kind of got rid of his tone. Other people we will keep treating. This was another gentleman. Unfortunately, where I live in BC, we have a lot of strokes after overdose, which is really tragic. And this man was getting stiffer and stiffer in his arm. So we treated him very early with botulinum toxin and the arm relaxed. So it stopped him from getting worse. So we, in multiple centers across Canada, you can get treated early if there is a physician that will do the treatments. So I'm extremely lucky. I have a team of spies. They are very aggressive spies. They're called physiotherapists and occupational therapists and nurses. And they look at all of our patients in the hospital and they phone us and say, I don't like how Mr. Jones is going. Mrs. Sidhu, she's developing tone. This isn't good. Can you come see? So we work really strongly with our therapists to decide when we're going to intervene to help the patient so their tone doesn't get worse. So the physiotherapist examining it and then me after treatment. So we work as a team with our spies. Now, most patients will not get treated early in the hospital. They'll get treated later. So this gentleman was sent to me because he's actually a guitarist and he just can't open those fingers. And he had tried some treatments with botulinum toxin and it wasn't strong enough. So I did one of those paralyzing blocks with lidocaine at a nerve right here in his wrist to open up the fingers, and lo and behold, with just a little bit of lidocaine for an hour and a half, he can open his fingers. So we add on some electrical stimulation on the back of his arm so that he can start practicing. So this would be a treatment option. We know that he has the ability to open his hand. He just has a lot of spasticity, and we're going to try to help him along. This would be the classic case of someone in the hospital who developed tone in their leg very fast. So you can see where her toe is going off. And we used to have a really nasty neurologist. We called him Voldemort because he was so mean and he wouldn't let us treat the patients. And you know, he didn't even believe this woman. And I said, I've never met a person who can bring their toe up that high. So she was in a lot of discomfort walking. And look where her toe is. So she was developing really bad spasticity quickly. So we were able to inject her when another neurologist was on call and asked us to come get help. And we treated her and she was up and walking the next week when she couldn't get her foot on the ground. So she was quite happy. We rely a lot on braces. So if you've had a stroke yourself, you may have different types of braces. There's little simple ones that will support your foot. There's more rigid ones. And then there's some electronic stimulators based on where you live in Canada and how much insurance you have that would cover an electrical brace to stimulate. Now, a lot of people will have tone that's just too bad. And there's very select centers in Canada where surgeons will help. And the surgeons are amazing. So this is an anesthesiologist that I work with. And you can see this poor woman, her shoulder does not move. So we did a block to release the pec, but it's still so tight that I called the surgeon to help. And this was one of our first surgical cases. She did nerve surgery to relax the elbow, and she did a tendon lengthening. So she relaxed the chest muscles to open her. So this woman's now in a much more comfortable position after working with a physiatrist like me, an anesthesiologist, and a surgeon. So we need a team to do this. Now, I'm going to talk a little bit about novel innovation today, because this is sort of my life right now. And we created an association called Canadian Advances in Neuroorthopedics for Spasticity Congress or Consortium. We have a free website. We actually have a conference coming up on November 11th virtually. You're all welcome to attend because it's free online on Zoom. We have experts coming from all over the world, coming in person and online to teach. And we're going to be doing a really deep dive on how to treat spasticity. Now, this is my research over the past 4 years on how to come up with a new way to treat spasticity. And we are doing it by getting rid of all drugs, getting rid of surgery as much as possible, and treating people by freezing the water in their body. So we are giving the body an ability to treat itself through a little twist of physics. So it's quite an exciting time in our world right now. And we are treating them with what is called cryoneurolysis. So we are going to inject that needle in your body. It's going to get so cold, minus 88 degrees, that it's going to cause the nerves to break down without drugs. We are doing a lot of teaching and training. These are the people that have attended our workshops in the last while. We also go and travel. So I taught in Oxford this summer, in Italy, Copenhagen, and people all around the world are trying to figure out what the heck is going on in Canada. It's really fun for me to teach. This team came up from Harvard recently. So our patients were treated over 2 days with the team from Harvard, learning on our novel treatment. We created a lot of buzz with our new technique, and there's so many great doctors around the world doing really great things. So my colleague, Dr. Winston, and I, the anesthesiologist, we asked about 30 experts around the world if they would help us create a book on how to do nerve blocks to improve spasticity care. Whether you're going to get injected with botulinum toxin or Botox, there's some drugs called phenol, whether you're going to get surgery or our treatment of cryoneurolysis. This textbook, which you can scan the code and go right to it, this will tell you how to optimize your care. So the providers, people or therapists or healthcare providers, it's something you could look to see if your library would get. Don't worry, we don't make a lot of money off the book, and it all goes back into research. Now, you started with a land acknowledgement. So I'm going to do my own here. This is Lisa Boivin. She is doing her PhD at U of T in rehab sciences. She is a force of nature. She will share her story. So it's her story, not mine. But we are exactly the same age. But because her father had polio, which is a Western disease, she was taken away, unknown to her, as a scoop survivor, same age as me, and raised by a family, and only found out in an adult that she was taken from home. And the reason was her father had polio, so he was a cripple and couldn't raise his child. So she met her birth family. She's got 2 loving families. But she really talks about how we take people and we don't really get consent, and we don't ask them what they want, and we force them to do things in medicine. And her father was sent to Edmonton from the far north multiple times for really invasive surgeries to rebuild his body from polio, and he had to keep escaping. And at the end of the day, whatever they did for the polio surgery, when he finally made it back home, his mother, who would just pull him on a sleigh for much of the year, turned him into a warrior dog sled champion. So her father was actually a champion in their culture, but we called him a cripple, because hospitals were for crippled children back then. So Lisa has really taught me how to celebrate the uniqueness of each patient. So everyone who comes to our clinic, we need to know their story, and we need to know why they're there and what they want and how they want to change. And so that's how I bring in Indigenous teachings into my clinic, is to make sure everybody feels safe with what we're going to do. And the way we do that is we are going to tell the future with them. So we developed cryoneurolysis. Now, this is actually another Indigenous patient who was admitted to hospital with quite a serious nerve disease. She had been declining for about many months and was given a lot of medical therapies. As we do in the hospital, we got rid of mask mandates, and she got COVID, poor thing, and was in the intensive care unit on oxygen. When she decided, when they let her come out onto the ward and got rid of her oxygen, she couldn't walk because she had such severe pain in her knee from arthritis. And she has an arthritic knee on the left, which was meant to have a surgery, but she was just way too sick to undergo surgery. So cryoneurolysis is something that's been used to freeze nerves and destroy them that cause pain for years. So what we did was we froze the nerves to her left knee, got rid of her pain, and she went from walking with my student, who's now doing his PhD at Western in London, to walking on her own very fast independently because she didn't have pain. So we know that cryo works for pain, and it's been used for 50 years. So in our clinic, we decided to have informed consent by doing nerve blocks. So we have taken every patient that has spasticity, and instead of having a crystal ball and saying, we're going to put you on some drugs or inject you with botulinum toxin or another drug or do surgery, we're going to do nerve blocks with ultrasound guidance. You're going to watch everything live on TV. We're going to block you, and you're going to end up at the disco parlor because you're going to know what's going on with all the excitement. So we're going to tell you the treatment that we think you're going to have. So we feel that this is true informed consent because we're going to tell you what we expect for you to get. We have designed this new technique. This is Dr. Eve Boissonneau, who is my fellow. She is in Montreal now, independent practice. And she's showing this is the live technique. It's fast forward just for your speed. But we put a needle catheter into the chest wall here. And we are going to look for the nerve. And in this case, it's the white line, the second white line in the middle of the screen. That's the nerve where she's going to start approaching with her needle. And you can see the needle going in. We are going to press a button, and gas, just like your whipped cream maker or your soda stream, is going to go through that tube. It's going to make the tube so cold that the water in your body will freeze. That nerve will get destroyed for up to 6 to 9 months and grow back perfectly fine. And you're going to see the way that man, his muscle just relaxed. So that's what cryo is. And here's another example. So it's a handheld procedure that we can do in the clinic, at your bed, at your long-term care facility, and even at home if needed. So I see a lot of patients that have failed treatment. So my colleague in Vancouver asked me to see this patient of hers. So he is very stiff. He doesn't have active movement in his arm, but you can see if you've had a stroke, you might recognize this pattern himself. So we figured out that if we froze the muscles with, well, temporarily paralyze the muscles to the chest, to the elbow, and a nerve, the funny bone nerve, which controls a lot of the hand, we could get him to relax. In the lower extremity, we have the problem that the leg is too long. So this woman actually has multiple sclerosis. She doesn't have a stroke, but it looks like a stroke leg. And she had been getting her treatments, not getting enough result. So we actually froze and destroyed the nerve behind the knee that causes all the muscles to work and the pain and sensation that she had. It will grow back about 9 to 12 months, but you can see how much better her leg moves. And she's actually able to lift that leg now and walk without her brace. So we are doing this every week in our clinic, more and more patients through our research and our hospital funding. So this is a man who has a very painful shoulder. Hemiplegic shoulder is the 4th most common disability after stroke, a painful shoulder. It is horrible. And we have no good literature in the Canadian best practice on how we should be treating it. So we actually take out the sensory branch that serves 70% of the shoulder. We can get rid of his pain. And then that contracture that he was told he'd never move his arm, we can get rid of it, as well as the one that keeps the hand stiff. So patient by patient, we are sent these people that we are told that have tone that I would almost call malignant tone, because they can't get their arm overhead, they have pain, they can't open their hands, they have a tight fist, they can't hold their spouse's hand, they can't touch their grandchild's face, they can't clean their nails. We are able to get rid of that with our novel procedure. There are surgical options as well in some parts of Canada, and we are starting to get this approach out. So you can see how stiff her hand was. Dr. Finlayson, she's trying so hard to open it, but after our procedure, it's immediate. This is the man that I showed you had the toe curling at the beginning. So he also, his stroke affected his whole right side, and he has difficulty opening his hands. They get stuck. We call that a dystonia. So we did one of the nerves, the funny bone nerve that causes the hand to close, and we found by blocking that we could get his hand to move. And because he is not a paralyzed stroke, he has movement, he has a beautiful moving hand now. It's quite emotional when this happens in clinic. Everybody generally bursts into tears, including the patient and me and everyone else, when someone gets their paralysis back. And this happens every week. We are able to return a degree of function to different patients. Some we can't because they don't, but some can, pick up a water bottle or feed themselves, which is really, really special. And you can see how tight he was before. Ev and I both have a dance background, and so we use a lot of movement analysis. And it's a very heavy research load and a lot of work. So we try to burn steam on our own just by figuring out movement together all the time on how to make things work. So this is the treatment that we're using, the freezing of the water. So just this handheld machine with a one-time usable probe, that's one per patient. And this is what it looks like. We just pass gas. So we actually don't pass gas. That's quite funny. We pass gas through the aperture and we cause it to drop in temperature and it freezes your water. So there's no drug. So we are replacing a very strong chemical with nothing. And for those of you that are a little bit nerdish, this is what it looks like. What's amazing about this procedure is that at the temperatures we choose, when we touch a nerve, we get the picture of the neuron that you've maybe seen a picture of what a nerve looks like to destroy. Now, you live in Sault Ste. Marie, much colder than Victoria, so we don't get minus 20 degrees ever, but you would get frostbite. And when you get frostbite, it's reversible, it would come back. So up to minus 20 degrees, you would get a frostbite. When you go to past Winnipeg temperature, to like minus 88, you actually destroy the nerve. So what happens is we get the nerve tissues to die, but nothing else. What's an amazing part of physics, that the blood vessels, the tissues, the structure of the nerve, everything is still there, but just the nerve disintegrates so it can grow right back. So it's really fascinating that this procedure allows it to grow back. Cryo is also used to kill tumors at a much colder temperature, and they use the gas argon to do that. We don't want to touch or damage any other tissue other than the nerve. And we don't harm blood vessels because they're full of heat, so it's good. So when we developed this technique, this would be a typical patient who would come to my clinic that I had injected. He was getting his Botox injections, or actually it was a different brand. And he doesn't have much movement in that arm. And we're showing that if you move it fast, it gets stuck. If you move it more, you get a bit more movement, but not a lot of functional movement. When we do our lidocaine block, we got rid of that fast catch and went right to his end. So it's easier for him to move that arm. So we knew he had potential. So this was our ground zero patient, the first patient we decided to do cryo, because my anesthesiologist said, well, why don't we do cryo to make this nerve block last? And he had been doing it for pain for decades. His machine was made in 1980 in Oxford. So we went ahead and we figured out how to localize it on ultrasound. And we did cryo, and you can see he has no patch anymore. His arm goes fully open. So that man who, to the best of our ability, was stiff, he's going, oh, wait, I can kind of open my arm. He had never practiced it before because he doesn't really pay attention to that arm. And what's happening, rather than having to repeat his injections, he's better at 6 months. He is now lifting up his grandkids. He clamps his hand on the lawnmower. He's mowing the lawn. He's doing all kinds of tasks. And 2 years later, he was still good. We have put cryo in multiple parts of his body ever since that time. So we went through case after case, muscle after muscle. And this is a child that has cerebral palsy. He's a teenager now, and he has this really tight muscle. And when people saw us starting to do this treatment, they thought, well, aren't you going to kill the nerve and shrink the muscle? But if you look on the left side in the green shirt, his muscle's quite spindly and small, and he's got a tendon sticking out there. But after the cryo, the muscle's big and long and quite beautiful looking. So if you look at the before and after, he's got a bigger muscle. And we've been noticing that when we lengthen the muscle, they have more strength.
So this is the approach. Dr. Boissonneau, can you explain what you're doing?
So I'm going to do a cryoneurolysis to the motor branch for the brachioradialis coming from the radial nerve.
So she is showing how she does this. Now, I know this is through March of Dimes, so we have just started a pediatric program at our hospital that I'm very excited about, because unfortunately lots of children have strokes. People don't realize that, but we have strokes from birth. So we have children who have strokes and cerebral palsy, brain surgery, and other causes. We do it under laughing gas on the pediatric unit to help them with their anxiety and pain for the procedure. So we developed this technique one by one of figuring out which muscles that people needed to get better. And I work a lot with international. So if anyone who's in therapy wants to take a screenshot of this or a picture, we developed something called the Viva algorithm, which is Verona Victoria, because it was done in Verona and my colleagues. And we show how to decide to treat someone after stroke. And it's something that we work a lot with our physiotherapists to identify the patients and how best to treat them.
Okay.
So again, this is a man who's just had a stroke on our ward. And you can see he's got a lot of pain in that shoulder and he's really stiff. But immediately after the procedure, he can't get his arm overhead, his arm goes right overhead. And it's really tight. And the biceps muscle is preventing him from opening. And the wrist is a little bit tight. But after the procedure, wrist is looser. And you can see the biceps. Tight the biceps is on the left and it's loosey on the right. So we are now doing one of our funded studies from our hospital foundation is to treat people within 16 weeks of stroke.
Also stiffness in the shoulder.
This is another one of our patients who chronically had a stroke. She was getting her Botox injections by my colleague, but wanted to do better. So we did nerve blocks to all over her body to decide which muscles we would target. And then you can see her after the procedure at 1 month, she's able to lift it better on her own, but look how loosey-goosey. And she's over 2.5 years from her procedure and she's thrilled. She never had to have it again. We also did her leg and she's part of a documentary that we've just filmed. She had to hold on and wear a brace. She now walks around her apartment vacuuming on her own and doing lots of cleaning and homemaking. She actually went back to work as a bookkeeper because she can now sit better and her hand actually works now. This was a patient that we just treated when the team from Harvard was here. He was born with this difficulty with his right arm, and at Vancouver Children's and the Shriners Hospital in the States, they don't know what is his condition, but he can't lift his arm overhead on his own, and he's a teacher. But a month later, he started lifting his arm, and the physiotherapist said he gained 50 degrees of range of motion because she asked him to, because he never thought of opening his arm before because he didn't know how. So we're really excited for the function that he is going to gain with physio over the next year. This is how it looks for shoulder pain. So we go to the back of the shoulder and we put in our needle and we freeze the nerve that provides shoulder pain. We are doing this for people who have arthritis and who can't get operations on their shoulder because it gets rid of 70% of the pain. Now I'm just going to share one of my favorite.
And then lift it to the side.
She lets us show her picture in her face.
And down and up.
I shouldn't have favorites.
Lift up. Great, and then bring it down and bring it out to the side this way.
Down.
Good, perfect. All right, and then.
So her shoulder pain was just getting worse and worse years after her stroke.
Perfect. So not really high tone.
But that's the range she
has.
has.
Her V3 or V1 maximum. V3, so she just doesn't like being moved. Very sore shoulder. That's it. So I'm bending the elbow, but it's only 90 degrees. And then her external rotation.
Ow, it's very painful.
So she cheats well.
So we treated the nerve pain muscle,
when I go to
the chest muscle, and the elbow movement muscle. And this is her right after the procedure.
And lift to the side. And then rotate it out to the side. And then towards me. Perfect. Oh, and straighten it out.
She's laughing.
And back. Crazy. Okay, now I'm going to do it. Oh!
I'm like a little Raggedy Ann.
I'm like a little Raggedy Ann. So I'll just let you know, she just came back about 1.5 years after the procedure because she has pain on the other side. She actually has another condition that affects the other arm, but her rotator cuff was quite destroyed. So she asked us, can we take out the pain? And she went from barely moving her arm to over. But we didn't have to repeat any of the muscles we treated before, but we now do some of the muscles in the armpit area, which really relax the muscles more. So we gave her more range of motion again. So this is another case of a man who's just had a stroke in hospital. And the occupational therapist said, Paul, it's a shame because he's starting to get recovery of his movements, but he's in so much pain he can't participate. And he's getting something called clonus, where when we move them, and if anyone's had a stroke on this line, you may have clonus yourself, where your body shakes uncontrollably. So we did cryo to the shoulder pain muscle, chest muscles, the elbow, and the one that was causing the shaking and stiffness in the hand. And actually, my colleague had just finished residency in Ottawa. It was his first week with me, and I trained him to do the procedure. And the guy is loosey-goosey. Shoulder pain is gone. He's able to lift his arm overhead. And you know what? We do it on Thursday at 4 o'clock. And he goes back to therapy on Friday. And they're like, what the heck did you just do to my patient? Because he showed up ready to go for therapy, really happy and no pain.
Okay, excuse the crazy hair, but I want y'all to see something that I haven't been able to do for 12 years.
So we get a lot of traveling patients. This woman comes from Texas. And you can see on the left, her movement before the procedure. On the right, she is showing me how she can box after the procedure. So she's quite happy. She could never touch her head. And then when she came back a year later, we added in the shoulder blade muscles, and her thumb is quite stiff, if you see on the left side. So by relaxing her thumb, you know, not only can she box, but she can now get up and do really fine motor stuff.
Ta-da!
And now I don't have to do it and get yelled at because I do it
So
terribly.
she's very, very happy with her procedure. Now,
And then
we
lift to the side.
mentioned we see children with
And
stroke.
go like this.
So this
And
is
then
a
lift to
girl
the
who had a
side.
stroke at the age of 10.
And go like this and do the same.
And the surgeon sent her to me because we wanted to lengthen the arm, the elbow, the biceps. The family didn't want to do any surgery yet. So we did cryo. And, you know, she never used that left
know
hand
that.
because it was very hard to open. And she walks with a brace and a limp.
Thank you.
And again, she came back a year
And
later.
down.
Results
Lift up
were
again.
so good that we added these
Get out to
muscles.
the side.
And she's so
Over the top. Go like this, up and down. Good. And straighten the arm out. Good. Open the hand. You open your fingers. Open and close. Good.
She uses that hand for a lot.
Whoa. Box you.
I can box myself.
Oh my god, that's super nice.
And yes, she can box. So after the first procedure, that was boxing. And after the second procedure, you can see how good use of her arm she has now. Now, this was her walking. So after her stroke, on the left side, you can see she's got a floppy way and her arm is held so tight at the side, she can't relax it. And when she comes back 4 months later, a year and so later, she's running now, she's playing soccer. So this is quite an emotional case. She's one of our patient partners that helps raise money for us. The family is just so happy that, you know, she has so much more function. And that was her walking before the procedure.
High as you can to the 5.
And this is one of our other
And down.
cerebral palsy
And
patients.
get out of the way, up to the top, to the side, over the top, go further.
She had traveled to the
Oh my
States
gosh,
to get
and down.
all different types of
And
type
out to the
treatment
side
to
this
help. And you know, in one
Go out
treatment
to the side.
session, she is
And just
much
swing
better.
it back and forth. As far as you can go behind you. And all the way here. Wow, okay. And straighten it out.
And I just want to acknowledge for anyone who's had a
Straighten it out.
stroke,
This is
particularly if you
crazy.
see your doctors
Here
in the
we go.
hospital, you had a stroke.
Whoa!
It's a pretty traumatic place.
Oh my
So
god.
many of our kids with cerebral palsy and our stroke
That's
patients are very
crazy.
traumatized
Look
by
at
the
that.
hospital because
Holy
they've had,
cow.
you know, they were in the ICU, they've had
Oh
their
my
own
god.
trauma,
Oh
their family.
my holy cow.
And these
I
kids
wasn't
had a
about
lot
to
of
say the same.
hospitalizations and a lot of needles from us over many years. So they hate the hospital, they hate needles. And the fact that we can do it once or once every few years is going to be really nice for them not to come back all the time.
Any movement?
We've introduced a few extra techniques. So my colleague from France is sitting beside me here who trains, and in France they do a lot more surgery. So this patient had a stroke, and I injected her with botulinum toxin for 12 years. And her arm always stuck in front of her when she walked, got in the way, and we couldn't raise it. We did cryo, and we got her to about here. So I decided that we would do our new technique, which is taking a little needle, putting it under skin, and scraping away at the tendon on the chest. And we're doing a case now. We're up to about 15 of these patients. So we just take a little needle, and we scrape away the tendon, and that's why her arm goes so high overhead.
So what was your hand like
So,
before we
you know,
did
one of the
meeting
things
there?
that we do this is because a lot of people
Okay,
have
and
twisted
so was it
hands
closed all the time or
after
part of the time?
stroke.
All the time. And why
And
did
I
you
smell
said
like
you
a
were the very
dead
first
fish,
person that we
said. And it was really embarrassing to him. So we started doing these ones to open up the hands, even if they could use them, so they looked easier to use, didn't smell, and people might not notice it as much. And this is how we are starting to get people with stroke and cerebral palsy to get more hand function with the procedure. So this woman, and she just came back 2 months after procedure, and she was another patient who her goal was to run. So you could see her jogging there. She wasn't able to run before. Now, I'm just going to try to get through the last 5 minutes to end. So about 9% of people who live in a nursing home have what's called
Completely.
hands.
Facility.
You may have a loved one that has it.
And then,
And it's
how does this feel?
Oh, good.
Good.
Feel bad, bro.
doesn't feel bad, bro. So the difference between what we do to
Wow,
all
so we're
the
able
other
to move the
injections is
fingers
we
now,
take
which is
away
a
the
big
sensory part,
difference.
the pain,
That,
and the motor function.
We're able,
So
if you
he
look
had
here,
skin breakdown all over
we can
his
see
body.
there's some maceration in the skin that we've opened up. And then these fingers.
So these patients are in
Able to
care homes
start
and
opening
homes
too.
all the time with skin breakdown, infections, going to hospital, and we now have a way to try to help it. And that's one of the clinical studies I have going right now on the contracted hand. This would be another dementia patient who, her nails are digging in. So her poor husband, every time he tries to move her, she's screaming out in pain for him, and he can't help her. And none of the treatments helped. But by doing our treatment, you can see her palm healed within a month. And this is another nursing home patient. He's got a really tight hand that we can't open. And my colleague asked to help because the staff were having a really hard time helping him.
Oh.
Okay.
Putting up with kids.
So we can open it now.
So now we can trim his nails, clean
Is
his
this hurting
palm.
at all?
He says, I have no
Can you say it
pain.
again?
No.
No pain? Okay.
So a
And
lot
we
of
can
these
now
patients
see
are
that
also
finger
being
that was
given
digging
all
in.
medications that
Let's see
make
if we
them
can get a
sedated, painkillers that make them sedated, and we're getting them off.
This is before a block. Can you open your hand?
All right, you can just raise your hand,
Come
Cheryl,
on,
if you
open
want
it.
me to stop the
Strong,
questions,
strong.
or I can
Open it.
keep going,
Open it.
whatever you
Open
prefer.
it.
We have quite a few questions.
Okay, so I'll just stop on this case because I have dozens of cases. But this is quite a fun case. So this is a man that has a stroke at a young age as a
So I'm
teenager.
gonna try closing
And
it.
he had a really good surgeon operate
Open
on
it
him,
again.
but he had that dystonia. So he couldn't open the
Open it
hand when he
and
wanted
close.
to. So we did one of
Open it
our
again.
blocks and figured out
So if he
which
puts
muscle
himself into
would
really
relax
nice
the
flexion,
hand.
you can do it in close.
So we did the block, and then we did the cryo to
And
relax
open it
those
again.
muscles. So now he has a
So
trick
I'm
that he
going
can do with that
Okay,
his
what can you do
hand.
with your hand?
He can make it stay open on his own
Okay.
now, enough to pick something up and carry.
Nice.
So it's really nice. All right, so
Can you move your foot?
I'm just gonna show you this one because it's fun. Okay.
Can you move your foot up and down for us? And what's different?
It moves. It's never moved before.
Let me see that again. So that's quite exciting.
Move. Look at that.
So this is what happens in nerve block clinic every day. So yeah, last foot case here. So here's a typical stroke patient. He had been my patient for years. We call him Mr. Giddy Up because he giddy ups, he can't catch up to his leg. And we do the cryo, and he is able to start walking better. And then we bring him back for physiotherapy, and he is walking very nicely. So a lot of these patients are able to get rid of their brace or wear their brace more comfortably. All right, so I'm gonna just end there because I have too many cases. All right.
Thank you. It's no wonder that you're quite passionate about that, looking at the results. The biggest overwhelming question across that we've seen is cost. Does private insurance cover it? Do any provinces cover it? And what is the cost?
Sure. So for stroke in Canada and just about every province, I think maybe PEI might be the outlier. We actually did a paper on this called Access to Botulinum Toxin Therapies, Focal Spasticity. It's covered in virtually every province, and that would be on your provincial regulations. So I know in Ontario it's covered for stroke. Sometimes it depends on the age, everyone up to 18, everyone over 65. Each province will be a little bit different, but every private insurance covers it for stroke. So in my province in British Columbia, we have what's called a deductible. You pay based on your family income. So everyone pays down their deductible. Toxin's expensive, so generally it knocks out their deductible. So most patients don't have to pay cash, but I have had patients that had to pay $2,000 treatment because it costs up to $2,400 4 times a year. The vast majority of my patients haven't had to pay, and they shouldn't throughout Canada. There might be a deductible based on where you live.
Okay. So I hope that it answers, because many questions came through about that. Would the chiro procedure work 2 years after a stroke?
Yes, so the majority of our patients are like 10, 12, 20, 30, 60 years after a stroke. So we basically do a block first to see if it will work. And that's why, particularly when patients have had to travel to see us, we do a video. My research assistants, because I'm not allowed to do telehealth in another province, they will see the patient, go through it, we'll get their doctor to send us a note, and then we would consider. So yeah, most of our patients, it's been a long, long time.
Okay, thank you. Has this been tried with patients with severe arthritis?
Yeah, so really wonderful question. So the one of the main uses of the device that I have in the States is actually to numb the knee before you have knee surgery replacement, so you don't have pain. So we do patients who can't have surgery on their knee. Because I'm funded for so limited, unless you have MS or a stroke or something, I've had to tell those patients, unfortunately, we're so limited. It costs us $800 for the probe. There are clinics in Ontario. And now there are other techniques that work on arthritis called radio frequency, which is using heat, which is offered in pain clinics around Canada. So that's an option. We are increasingly trying to offer, but we're really reserving our allotment of probes to neurologic disability. But many of my patients who've had a stroke, they need it on the knee on their good side. So we will just do it at the same time. We're doing a lot of non-operative people who have cancer who can't undergo surgery. So I will give, I hate charging patients. It's my least thing. So it's only like 4 or 5% of patients we've had to charge. And it's simply because we ran out of stock that month and they wanted it for pain, not for neurologic disability.
How many times can you repeat the cryo treatment on the same nerve? Is there a limit to it?
That's an amazing question. So cryo started in the 70s as a pain treatment for things like trigeminal neuralgia or nerve pain. So they can repeat it. They would do it when the nerve grew back and the pain, or on an average about 6 months. So it's unlimited. The nerve grows back perfectly well, and there's good studies from on animals showing that it grows back. So you destroy it, but it comes back. We have thankfully not had to repeat it that often. There's some people with that dystonia where they have that weird twisting movement. As soon as the nerve grows back, the brain tells it to go again. But very few people have had multiple treatments. You know, the average would be maybe 2, and it's so easy to repeat on that one nerve that it's no problem.
Okay. And you just actually mentioned trigeminal neurological pain. Would this work on that?
Yeah, so the probe that I have is too big. There's a smaller probe. And there's a woman in Florida, Andrea Trescott. She invented most cryo. She's an amazing woman, and she does it for that procedure. But it's not my forte, and I'm not going to do it just because I'm worried about weakening the facial muscles, but there are options.
Okay. Do you know of anybody in the US doing this?
So I have been training a lot of Americans. So Dr. Sheng Li, that's L-I, in Houston, now has 2 clinics. And Dr. Clay Gwynn, that's G-U-Y-N-N, in Atlanta. The Harvard group is looking at purchasing. Many groups are looking at starting. It's the same thing. It's about getting insurers. Now, the US is crazy because when you get one Botox injection, they will charge your insurer $20,000, even if the medication here costs $2,000 and they're $5,000 or $4,000, because they charge all kinds of fees just to use the hospital. So in Dr. Gwynn will do it in his clinic so that it doesn't have this.
What kind of wait list is there to see you?
We have 4 doctors in my clinic that are doing it, and this is our priority. So the wait list is pretty short. We generally book people and then book them for treatment within 6 weeks. So sometimes the wait list is 2 days, sometimes it's 4 weeks, 6 weeks, but it's pretty short because we've done that. And we're really in the process of trying to find more funding. The hospital's giving us more because we're not allowed to really charge the patient in the hospital. So we're in this weird, just to give you an example, this treatment, which would cost, we buy it for about $650. That replaces up to $9,000 in costs in a year. So we're trying to convince the government that you could save, between $5,000 and $9,000 per patient per year, and that's every year. So hopefully we'll get it on formulary. My colleagues in Alberta are working hard to get it covered.
Right. Will this help neuropathy?
Really good question. So my colleague, I'm probably going to Copenhagen soon. So Copenhagen is where Novo Nordisk is, the biggest, wealthiest company in the world that does diabetes care. And they have a lot of money. So he is starting a study at diabetic neuropathy on freezing the nerves that cause the diabetic pain. So we have been doing some pain at the top of the foot. It's something that, these are all things, in order for me to get it funded, I need to test patients, but I need a research grant. And these are the things that we're trying to partner. So I'd love to do that study. But again, I need a research grant funder. So if anyone has diabetic neuropathy and has connections and want to find out, I'm your guy. We just need some kind of funding to make it happen.
Okay. In patients with connective tissue disorders such as Ehlers-Danlos, how does spasticity need changes in treatment?
That's a wonderful question. So Ehlers-Danlos is flexibility, hypermobility. So these are bendy bodies. And in some people, it can be very protective in spasticity because they have more looseness, more play. So they might be luckier, but they also have joints that might sort of dislocate and sublux. So they're more prone to having pain. So in my experience, Ehlers-Danlos patients have a lot of pain with spasticity.
Okay, so this would potentially help that. Okay. I'm sorry, I'm butchering these names. Neurosarcoidosis.
Neurosarcoidosis.
When lower muscles are tight, when straightening legs or turning over in bed, the body suddenly tightens for a few seconds. Is this actually spasticity?
No, it's probably a different pathway. It's probably, it depends on what's happening in the brain. It could be spasticity, to have to assess it. I was just talking to my colleague today that our procedures, even toxin is meant for spasticity, but we use it in Parkinson's. We use it in many disorders to relax muscles. So there's many treatments that might have different disorders. It's basically a disorder of muscle. If someone just has a tightness that relaxes, we generally don't treat that because we don't want to make them weaker, but there's always a possibility that's happening a lot.
Okay. Is this recognized by all physiatrists?
My new technique or
Yeah.
So I have a lot of friends across Canada and all my colleagues are there and I presented. So a lot of people, it's still new. We're going to be doing a major data dump in the next 6 months. We've got multiple papers going to publication, which hopefully will change. So I don't think I'd have a single colleague that would say, no, you can't see my patient, because they're sending me their patients. Many of them want to do it. They're coming for training. It's literally that, how do I raise the $650 per patient? Because that's how it works in Canada. We don't look at cost savings. We look at what's covered and not. So I don't think anyone would say, no, you can't have this. And what I'm trying to do with our textbook is get my colleagues to, even the company that makes Botox bought 100 copies of our book to give to people to do blocks to see how they could give care better. So I'm encouraging my colleagues to try to do the blocks themselves to see if they need treatment. And we're trying to get more clinics across Canada. So one in Montreal should be opening soon. There's someone in Ottawa. There's a doctor in Ottawa who will do it, and a doctor, they just have to get all the equipment and stuff.
Okay, so in Ontario, there's Ottawa. Is there any in Toronto?
No, I just treated a patient from Toronto, a child and an adult from Toronto who loved it. Their doctors are very supportive. My PhD student is starting a research project at Western. So they will be recruiting people when that's funded. So in London, there will be the possibility to be treated.
Okay. And what is the actual referral process?
To see me, it's a bit convoluted because you're not allowed, under Canadian law, you can't get referred to me if you're from out of BC. So what I generally do is just get people to contact, not hard to find our contact in Victoria, and send a referral. And then, as I said, my research assistant will contact you, because those Canadian colleges, the last thing they want me to do is help you. They're protecting the public. They hate out of province. They hate other doctors and patients. No one knows why. So we do a screen, and my research, who's actually a physician, a trained physician in Iran, so she's highly talented, she will tell you if you would benefit or not. And then we come out And I generally have been doing the out of province people on our big study days because I get a donation of probes for those treatments. So it doesn't cost me anything. So I can argue I'm not taking money away from people in BC.
Sorry, can you just clarify, is the chiro method done before, after, or in conjunction with the Botox type treatment?
So generally, 99% of people, unless they've just had a stroke, have had multiple rounds of Botox, and that's why they're referred to me, because it's not lasting or working enough. You can always have it after, but what we find is they generally don't need it after. We might do it in a small group of muscles that we didn't treat just to kind of top it up, or if you lived in another province, you might need to get that topped up because you can't get it. You know, we are not getting rid of toxin. I still inject toxin. This is our research area. They've been actually very supportive of me in terms of funding for the difficult patient. So, you know, in rehab, we say, you know, just like I work with a physio and OT, I work with toxin and cryo and surgeons. Like, we're all working to give the best outcome. We don't want to pick a side.
Okay. What about headaches from a stroke?
Very interesting. So headaches with stroke, when they're migraines, we treat those with Botox. I have a large Botox program. The company that did this one has a really small little probe, and they just did a study on headaches. So I've done a few on this, and it's kind of like when people come in for their spasticity with stroke, I do their migraines at the same time. You know, I have one patient that I'll probably be doing the headaches with their spasticity as well.
Okay, just a last couple. There are a few people in Ontario who are looking for the doctor in Ottawa. Would they find that on that's a tricky one.
No. I don't know if she got a demo of the device. She's very talented with nerve procedures, Dr. Jennifer McDonald. You know, if someone at your association could take an email, I could get that information, but I don't want to give out her information. No. She's not set up for it yet, but she would really like to do it.
Okay. And I think that we're going to end there. You have definitely answered the good proportion of the questions in the chat. This has been absolutely fantastic. Thank you very much. If anybody does have more questions, please email them to me, and I can forward them as appropriate.
I'm also on Twitter, where most people find out about us. It's just at Dr. Paul Winston, all lowercase. It's not doom and gloom. It's the only place without doom and gloom on Twitter right now. So many people have seen our cases and got in touch with us. I have to tell you, I have never seen 58 questions in a chat box. So that's such a great I don't know if you have some way to print these out for me or save them. I don't know, because there's too many to read, but if you have some way, I could try to answer them and send them back to you.
For sure. Sounds good.
Okay.
Okay. Thank you very much for taking your time out of your day to be with us today. And the recording of this will be ready roughly at the beginning of next week. And a thank you will go out tomorrow with the PowerPoint presentation attached to it.
Sure. If I say one last thing, like, all of my colleagues across the country want to do this. So if any of you are connected to, you know, through March of Dimes, through other agencies, you know, if we can come up with a protocol, I can easily find the doctors who will do the study in your center. It's just, as physicians, the Canadian Granting Associations see us as full-time clinicians. We score very low on the totem pole for funding because they're looking at full research labs. But most of us are in full-time clinical practice doing research. So if anyone wants it in their center, you know, happy to partner with you to get something funded. The doctors are easy to train.
Perfect. Thank you very, very much. Have a great day, everybody.
Okay, take care.